Good morning, respected judges. I am going to present a case report on sight-threatening orbital cellulitis from osteometal sinuses due to mixed infection. There is no financial support. Orbital cellulitis is a serious infection that involve muscles and fat located within the orbit. The causative organisms are bacterial but also polymicrobial, including aerobic, anaerobic, and fungal and mycobacterium. It is important to diagnose the investigate to determine if the source is from the sinuses, as it is closely associated with the orbits and are commonly the source of infection. Treatment with antibiotics for aerobes and anaerobes is important along with the antifungal drug when fungal infection is suspected. It requires multidisciplinary team of ophthalmologists, endospecialists, infection specialists, and neurosurgeon. Here, a 55 years diabetic male presented with swelling of the left side of the face, diminution of vision of left eye, pain, ptosis since last 7 days. He is a known case of diabetic for last 10 years with CKD. He had fever, pallor, and central obesity. His visual acuity in right eye is 6/12 and in left eye is finger count in 3 meter. Anterior segment of right eye was normal with few dot humerus with and hard exudate. In their left eye, there is a swelling of the lids, severe ptosis, erythema, tenderness, mild ptosis, total ophthalmoplegia, and swelling of the left side of the face. IOP is digitally high. Anterior segment of the left side shows severe congestion, chemosis, sluggish reacting pupil, and early cataractous changes. Few dot humerus and hard exudate surrounding the macula in the retina. He developed pustular swelling in the left maxillary area 3 to 4 mm in after 11 days. The blood parameter dearens with increased WBC, neutrophil, sugar, urea creatinine, and decrease in hemoglobin and other blood parameters. CT, nose, and PNS shows mucosal thickening and multiple air focus in the left maxillary sinus and ethmoidal air cells. Rectal muscles are edematous on the left side with intraconal fat standing. Inferior terminates are hypertrophic. It suggested an osteometal pattern of sinusitis. MRI orbit shows ill-defined collection with soft tissue swelling involving the left orbitozygomatic, maxillary, and mandibular area. There are left or retroorbital inflammatory changes with proptosis suggesting of the orbital cellulitis. The optic nerve shows normal intensity. So it's a case of orbital cellulitis with left-sided osteometal sinusitis. Initially, he was treated with broad-spectrum antibiotics, piperacillin and tazobactam, insulin, and analgesic anti-inflammatory drugs, and antibiotic drops, eye drops, and ointment. Culture centimeter pass shows Klebsiella pneumoniae, and blood culture shows coagulous negative staphylococcus. Thus, it's a orbital cellulitis due to mixed infection. He was switched to IV linezolide, clindamycin, and liposomal amphotericin B along with the previous medication. He received the medication for 7 days. There was a general improvement, but the vision is deteriorating and to PL negative, and ultimately it gone to optic atrophy. So this is the pictures day 1, day 4, and day 14, and the right side shows the past culture showing Klebsiella pneumoniae and blood culture coagulous negative staphylococcus. It's a left side shows CT, nose, and PNS. Left eye shows edematous proptosis with edematous medial rectus muscle, and right eye shows the MRI pictures. Discussion: severe optic cellulitis is a mixed infection due to osteomyelitis characterized by multiple carina pulses, which cause pain, decreased visual acuity, ptosis, total ophthalmoplegia, and visual loss occur due to mechanical pressure of the inflamed orbital structure, which leads to the increased IOP, reduced retinal circulation, direct compressive optic neuropathy, or ischemic optic neuropathy. Retinal also show such kind of cell MRSA, but lost the visions. Klebsiella pneumoniae is developed capsule composed of polysaccharide which inhibits the phagocytosis of the host and causes severe invasive disease. As the sinuses of the cavities increases, the ostia appears to be narrow with increasing age, which creating optimal condition for anaerobic bacterial growth. With increasing age, there is a trend towards the more complex infection. Aerobes consume oxygen and which encourage the anaerobes to grow. Additionally, anaerobe produce beta-lactamase which inhibit antibiotic ineffective. Conclusion: here we report a case of rapidly progressive orbital cellulitis due to coagulous negative staphylococcus aureus and Klebsiella pneumoniae in an immunochromopatous male, resulting in visual loss and optic atrophy. To conclude, orbital cellulitis warrant a prompt diagnosis, medical and surgical management. There declaration for patient is taken, and there is no conflict of interest. Thank you. These are my references.
Thank you, Dr. Kalita, for a good presentation. So, just a question. Why did you choose this particular case report, and what is the main take-home message that you want to give us?
Because we should not neglect orbital cellulitis case, because it may be complex. It may lead to visual loss, because he was on ICU setting with taking treatment from oral to IV, but in spite of all treatment, patient lost the visions within 11 days. That's the problem.
What is the cause of decreased vision in this patient?
Yes, ma'am. Yes, ma'am. Yes, ma'am. At last 11 days, he was PL negative, ma'am. Because ma'am, due to orbitals, due to inflammation, there is pressure in the increased pressure in the rest, increased pressure in the orbit, which led to compressive optic neuropathy, optic neuritis. Because he is a case of diabetic patient, a long-standing diabetic patient. Okay. Already, ma'am, he has a some diabetic retinopathic changes in the retina, ma'am.
Did you get an ENT examination to rule out some fungal sinusitis or anything?
Actually, ENT people also see, but it was not, ma'am. There is no fungal sinusitis, ma'am.
Did you get his COVID test also done?
Yes, ma'am. No COVID, ma'am.
Dr. Shalini, any questions for the speaker? All right, so we go on to the next speaker.
Thank you, ma'am.
Thank you so much.